So I have uh, divided my talk into 7 areas and 7 errors in outpatient practice. Uh, these are very few of what I would like to share. So with half an hour to go, this is what I have for you. Next slide. Just a second, I'm just the first thing, the first error that we make in the OPD is called the 11-second interruption. 11-second interruption means that the patient comes to you, starts giving the history, and you interrupt the patient on an average in 11 seconds. This was a study made in Europe and in the US. There is no Indian study. But once the patient starts talking, we stop the patient in 11 seconds. That is something that you cannot do. As William Osler said, listen to the patient. The patient is telling you the diagnosis. As outpatient physicians, our primary responsibility is not treating the patient. Our primary responsibility is diagnosing correctly. Secondary responsibility is treating the patient. So if you do not diagnose, obviously we know that we cannot treat properly. The most important way to diagnose a patient is to listen to the patient. Don't interrupt the patient. There are 2 or 3 suggestions that I have for you. The patient starts talking to you. First, just say, Haji, Biju, Bolo. That is all you have to say. Interjections are just 1-syllable interjections. When the patient starts floundering, meaning patient after saying, मुझे बुखार आ रहा है 15 दिन से और 101 तक आता है, मैंने फलाने डॉक्टर को दिखाया, उसने मुझे ऑगमेंटिन दी. Stop the patient when the patient starts talking about investigations or treatment, because you want to hear the symptoms first. Make the patient stay with symptoms. Tell him, मुझे आपने क्या ट्रीटमेंट किया, क्या टेस्ट किए, उसमें बिल्कुल इंटरेस्ट अभी नहीं है. You tell me your symptoms, your complaints. आपकी कहानी सुनाइए. Let the patient continue with that. That is one suggestion that I would make. Other suggestion is never let the relative give the history if the patient can talk. You will often realize, especially in these days of telephonic consultation, first the relative will call you. He will start saying कि patient ने पेट में दुखे छे, ने patient ने आम थाई छे, तेम थाई छे. Don't listen to the relative. Don't waste your time with the relative. Tell the relative, if the patient is awake, I want to talk to the patient. If the patient is sleeping, call me when the patient is awake. That is how blunt you have to be with the relative. I don't want to listen to you first. Unless the patient is unconscious, incapacitated, Alzheimer's, etc. You may want to then listen only to the relative. That is fine. Otherwise, don't take the case history first from relative. Later on, you may add on something from the relative. Third question. Third suggestion. We often, in history taking, after 11 seconds I have lapsed, the patient has told the story. We often see that the patient meanders, goes wayward. We have to now start asking leading questions. पेट में दर्द है, ऊपर के भाग में दर्द है, and he is rambling, and then you ask him specifics. कल खाने में क्या खाया था, alcohol कितना लेता, whatever specifics come to your mind, ask him specific leading questions. So leading questions are extremely crucial, but only after the patient has had his or her say. So first message is, do not fall to the 11-second interruption problem. Let's go to the second question. Second error that we make is called the missing the mule mistake. If you know, there's a very interesting saying or an aphorism in medicine. You hear hoof beats, think of horses, not zebras. તમને તબડીક તબડીક સંભળાય, તમારી પાછળથી અવાજ આવતો હોય, તો તમારે વિચારવાનું કે આ ઘોડા છે એમ ના વિચારે કે ઝીબ્રા છે. That means think of common things first. Don't think of rare things. That everybody knows this maxim. Anu ek addition. There is an addition to that. When you hear hoofbeats, think of horses, not zebras. But don't miss the mules. એટલે ખચ્ચર પણ હોઈ શકે, ફક્ત ઘોડા હોઈ શકે એવું નહીં. You can even have mules, and mules are not as rare as zebras, maybe not as common as horses. So how do you suspect the mule? For example, if the patient comes with acute epigastric pain, and when the patient is describing alcohol, etc., you will say acute gastritis seems to be the problem, and you will give some PPI or some liquid antacid. If you have not taken the history correctly, you will miss the fact that the patient is complaining of severe continuous pain that radiates to the back and is better by bending forwards. In an alcohol consumer, pancreatitis becomes the mule. Not very rare, not as common as gastritis due to alcohol, but not to be missed. In every condition that you are presented with, you must think of the mule, not just the horse. We also have a problem that's called the anchoring bias. Anchoring bias, when the patient comes to you, within a minute of talking to the patient, your diagnosis is anchored, meaning you have a diagnosis that this is definitely a migraine. Now, anchoring bias means that till the end of the consultation with the patient, even if the patient has more story to tell, your diagnosis remains migraine. And then you don't pay attention to clues to another diagnosis. Never have an anchoring bias. And for not to have an anchoring bias, the method, how not to have an anchoring bias, the method is write down the history of the patient as the patient is speaking, whether it is outpatient live consultation or telephonic consultation. I like to keep a pen and paper with me and keep on writing what the patient is saying. When I write, I don't anchor my diagnosis. I don't make my diagnosis fixed within 1 minute of the patient talking. In that way, you may say, okay, I thought it was migraine in the first 1 or 2 minutes. Now I know it is not migraine, and I might have to do an imaging of the brain. This is how you will not miss the mule. So that is my second suggestion. Don't miss the mule. The third suggestion is this. Don't make the error of believing the patient's self-diagnosis. Many times the patient will come to you and say, okay, I have chronic sinusitis. Very common presentation. The patient comes with the diagnosis. I have recurrent or chronic sinusitis. Then you ask the patient, I don't want the diagnosis, but please give me all your symptoms. When the patient is giving symptoms, he says, I have pain on one side of the face and I have severe throbbing headache and I have nausea and vomiting. Now you know that sinusitis has been diagnosed by somebody, but the patient actually has migraine. Don't believe that. One sometimes patient will come to you and say, Juno Murdo, very common diagnosis made by Gujarati patients on themselves. Juno Murdo. Now, what is Juno Murdo? In medical science, there is nothing like chronic amoebiasis. There is nothing like Juno Murdo. So then you have to go into the patient's history carefully. And the patient say, since 1 year, I have recurrent diarrhea with abdominal colic. And now you may be able to correctly diagnose irritable bowel syndrome instead of the chronic amoebiasis. Patient self-diagnosis should not be considered as the correct diagnosis. Sometimes we make that mistake. Let's go to the next error that we make. Error of treating the report and not the patient. Now, this works both ways. Some reports are worth treating even if the patient is asymptomatic. some reports are being treated by us, even if they are not needed, the treatment is not needed. Let me give you an example. A patient comes to you with a complete health checkup report. The file contains a few abnormal reports. For example, the uric acid is 8. You ask the patient, have you had gout-like pain before? The patient says no. You ask the patient, have you ever had kidney stones? The patient says no. The patient has no CKD, just a uric acid of 8. You ask the patient if he takes alcohol and this report, and after alcohol, does he get joint pains? No. You rule out all the symptomatology or disease related to uric acid. But at 8 uric acid, so many of us start either febuxostat or allopurinol, Xyloric or febuxostat. Many of us will start at 8. Now, evidence-based medicine says we should start in asymptomatic patients treatment for hyperuricemia only if the uric acid is 11. Now, if you know the science, you will not make this mistake. Try to know the science behind every prescription that you give. Most of our learning is a hand-me-down learning, meaning somebody else has been doing that. You have seen consultants prescribe febuxostat for uric acid of 8. You will probably start prescribing. But just it is with the advent of availability of literature on Medscape, up to date, etc. Most of it is free. You can easily find out whether treating uric acid is good or not if the patient is asymptomatic. You know that Xyloric or allopurinol can cause a significant skin rash. You know that febuxostat can increase cardiovascular mortality, which comes now as a black box warning in the US. You cannot overtreat a patient if the patient is asymptomatic in this area. Another error, for example, I'm just giving examples here. Another error is in the lipid profile. Most of us treat lipid profile when there is no treatment necessary. You see a patient with an LDL cholesterol of 165. Patient is 45 years old, no other risk factors. A 165 LDL cholesterol looks bad, and the patient also is worried. But you know that evidence says that in a patient who does not have diabetes or atherosclerotic cardiovascular disease or a 10-year risk score of more than 7.5%, if the patient does not fit into these categories of prescribing statins, then an absolute value of 190 LDL is the only indication of treating cholesterol with statins. So you can't treat cholesterol with statins in everybody who has 160 LDL. Similarly, in triglycerides, many of us, because we have the armamentarium, we have a drug to prescribe, and a triglyceride level of 285, 320, 400 becomes a reason for giving fenofibrate. No, fenofibrate has very specific indications. Absolute value of triglyceride above 1000 is an absolute indication. Value above 500 in diabetics is an absolute indication. Value about 250 in very aggressive atherosclerotic disease is an absolute indication of giving fenofibrate. But when you see the health checkup report and you see 400 triglyceride, patient is non-alcoholic, non-diabetic, patient has no other problem, just family history of hypertriglyceridemia, 400 is not the reason for giving. So we must know the science and the evidence-based prescribing pattern in triglyceride, in uric acid. So these are just some examples. Another area that I'm worried about errors happen is when you see a CBC report and see eosinophilia 10% out of a total count of 10,000. This eosinophilia will often attract treatment with diethyl carbamazine, meaning you will give hetrazan to this patient very commonly. Now, hetrazan or treatment for eosinophilia of filarial origin, that's called tropical pulmonary eosinophilia. It has very specific area indications. You have to have an absolute eosinophil count of 2,000 or more. You have to have history of patient coming with recurrent rigors and fever. You can't give hetrazan to anybody, everybody. with 10% or 8% eosinophil. You may give a deworming, but you can't give hetrazine. So you are treating the report. Ask the patient whether the patient has any problems. There are some areas where the patient has to be treated, not just report has to be treated, even if the patient is asymptomatic. There are some areas, and you have to recognize those small areas where the patient must be treated, even if no symptoms. For example, a very simple example. If the patient has fasting blood sugar of 150 and post lunch of 250, and this was routinely found, you have to give the patient first advice regarding lifestyle and diet. And if the sugars remain this high after say 3 months of lifestyle and diet, you have to treat the patient. There is no question of not treating the patient, even if the patient is asymptomatic. So there are some reports which demand treatment and some reports that don't. So you will obviously know much more about many such reports which demand treatment. For example, I give you an example of LDL cholesterol 190 or more, asymptomatic, even if the patient is 25 years old. If the LDL is 190, you will treat the patient with statin because that is the indication. 190 or more have to treat. So there are some areas, but most of the time the error is in over treating the report rather than the patient. That is about the error number 4. Let's go to the error number 5. This is a very interesting error, and I sometimes kind of get angry when I see prescriptions. I should not. But if, many of us have the OCD error, obsessive compulsive drugging. We give drugs if the patient even mentions a symptom. We don't ask the patient, do you want treatment for this? Are you uncomfortable such that you need treatment for this? Simplest example, knee pain. The patient comes to you with several years of knee osteoarthritis. Patient says, I have knee pain, I have difficulty in walking, and you will prescribe NSAIDs for 5 to 10 days. And you not ask the patient, તમને દવાની જરૂર લાગે છે તો આપો. તમને દવાની જરૂર છે ને ક્રોસિનથી મળતું હોય તો ખાલી ક્રોસિન લઈએ. If you think you will be better with just a local application of diclofenac gel, let us do that. But our automatism, our ball pens are so used to writing diclofenac or ibuprofen because just because the patient utters the word pain, that should not happen. We should not be obsessive, compulsive drug prescribers. We cannot do that. Every symptom need not be treated. A patient of diabetes will come with paresthesias in the legs. Our automatic prescription of pregabalin or gabapentin comes in. Ask the patient, is it disturbing to you? Is your sleep disturbed? Are you very upset with this? Then I can give you something. I can give you some drugs if you are. Don't use such drugs like pregabalin, gabapentin, amitriptyline very easily. You have patients. I have seen patients in my initial OCD days when I prescribed amitriptyline straight away 25 milligram HS. I have had patients who fell down and fractured themselves. You will have in your life 1 or 2 such patients who actually were harmed significantly, not just mild giddiness and headache. You were harmed significantly by our prescription of pregabalin, gabapentin, etc. Don't make that mistake. Another area in this drugging part is underdose symptomatic treatment and correctly dose specific treatment. I will repeat this, and this is something that I want you to take with you. Underdose symptomatic treatment, correctly dose specific treatment. For example, if the patient has post-herpetic neuralgia and you want to relieve the pain, this is symptomatic treatment. You will give this patient medicines starting with paracetamol and then go ahead with opioids or anticonvulsants like pregabalin, gabapentin, and underdose these drugs. I've seen prescriptions by orthopedic surgeons of carbanuron 300 TDS on the first day of prescription. You try to take 300 milligram one tablet of gabapentin, and you will feel miserable. You will be lucky if you don't fall and fracture yourself. You have to start low and go slow. Start low and go slow in symptomatic treatment, especially in geriatric patients. You have to give gabapentin 100 milligrams. Warn the patient that giddiness will happen. Then increase after 2-3 days to 200 and then to 300 maybe. You can step up the dose gradually rather than bombard the patient with a high dose of gabapentin. Never start with pregabalin. Never start with pregabalin. Pregabalin 75 milligram is equal to almost 400 milligram of gabapentin. 50 milligram pregabalin is available, which is also around 300 milligram of gabapentin. Never start with pregabalin. There is no lower strength available for titration. Amitriptyline. You give 10 milligram of amitriptyline somebody at night and they will have problems because some people are very poor metabolizers of amitriptyline. Some people are ultra rapid metabolizers. So the range, and this is a scientific fact, the range of tolerance to amitriptyline is sometimes 500 milligrams in some patients who rapidly metabolize the drug. And in some patients, it is not even 5 milligrams. The range is huge of individual variation. We call this genetic polymorphism. If you are giving amitriptyline or nortriptyline to a patient, start with 5 milligrams of amitriptyline, half tablet of 10 milligrams. Tell the patient in 2 days you tolerate it, third day you make it 10 milligrams. Go slow, start low should be the dictum in symptomatic treatment. In specific treatment, for example, you're treating herpes zoster, when the rash is active, the patients come to you within 72 hours. In specific treatment of acyclovir, valacyclovir, famciclovir, you have to give the correct dose for the correct duration. I have seen prescriptions of acyclovir 200 milligrams TDS. Obviously, we know the correct prescription, right? 800 milligrams 5 times a day, or valacyclovir 1000 milligrams 3 times a day. We have to give the correct dose, and the duration has not to be compromised. It has to be minimum 7 days or till the vesicles disappear, which may take 2 weeks. So never make the mistake of underdosing specific therapy. I'm also upset with prescriptions of sleep medicines. The specific treatment for chronic insomnia is not hypnotic drugs like lorazepam or the Z drugs, zolpidem, etc. Treatment is behavioral change and maybe some form of cognitive behavioral therapy. That is the specific treatment of chronic insomnia. But we are used to giving sleep medicine. Even then, if you give them, read about them and understand that you can't give zolpidem more than 5 milligram in women. Now, this is evidence-based. 10 milligrams zolpidem in women can cause significant drowsiness daytime. They do not metabolize zolpidem as well as men. So in men, the dose can be 10 milligrams. In women, it has to be not more than 5 milligrams. So this is about error number 5. Let's go to the error number 6. We can add, we do not subtract. What is the meaning of that? A patient comes to you with hypertension, is already on 3 drugs, ARB, amlodipine, and a beta blocker. And now the patient BP is 170 by 100. Our natural thing to do is add a drug. Say we add moxinidine or any alpha blocker. We have not subtracted. We have not realized that these 3 medicines are not working that are already on. Can I remove one and add another? Think of that. Ask the patient, which was the first medicine started? Amlodipine was the first medicine started. Amlodipine has not worked in 6 months. Remove amlodipine and add your new drug. You must subtract. For example, a patient is on long-term combination of tamsulosin and finasteride for prostate. We do know that finasteride reduces prostate size. Tamsulosin is for symptomatic relief of obstruction. After 6 months, the prostate size goes down. That time, why can't we remove the tamsulosin portion if the patient is asymptomatic and just try finasteride? We can. Patient might tolerate it very well. There is no need to give the symptomatic drug with a specific drug for life. We have to subtract. Just don't keep adding. And remember, 5 or more drugs is called polypharmacy. And in geriatrics, every drug added after 5 drugs will cause minimum one side effect. Every drug, not, not just specific treatment, even symptomatic treatment, even supplements like calcium, every drug added will cause one additional side effect in geriatric patients. So another area that I am upset with is giving domperidone with PPI and giving it for life. If the patient has significant hiatus hernia and GERD, you don't need domperidone for life. Once the patient is relieved, remove the domperidone component and just give the PPI, even if it's a large hiatus hernia with significant reflux. There is no evidence of lifelong domperidone for even such patients. Subtract the domperidone portion of the combination. Yeah, so that is about sixth error, and the last error, I know I'm about time, is the error of failure to unlearn. Medicine is all about unlearning and new learning that we must do. We are in the field where we can harm patients significantly, and we've seen it all around. I have harmed many patients. I may be responsible for death of some patients, and I have to improve myself every day. Not just because the patient has to be saved, but also because the satisfaction of doing everything correctly means your life becomes so much more rewarding when you don't make mistakes. And the commonest mistake is not unlearning. If you have to give an example, in diagnostic testing, since 1896, we have been doing Vidal test, 125-year-old test. Since several decades, we have known that Vidal has no value. Umpteen recommendations with umpteen papers and studies have shown that Vidal is useless to diagnose enteric fever. My take is that not only Vidal is useless, it is harmful. It is harmful because it leads you away from the correct diagnosis. Vidal can be positive in dengue and in malaria and in meningitis and in tuberculosis, because Vidal can be positive in so many conditions. And we still do Vidal and not blood culture. We have not unlearned. We have to. We have to. I give an oath to my students. I will never do Vidal in my life. We have to unlearn that. In the US, people have not unlearned that primary prophylaxis aspirin is useless. People take aspirin, maybe aspirin they call it, but they have not unlearned that primary prophylaxis aspirin causes more harm than good. Unlearning is a process that we have to get accustomed to. Well, that's my talk. I'm sure that we will 5-10 minutes for the question answers. So, would love you to ask questions.
Thank you, sir. It was a very, very lucid information, and as you rightly said, it is very important to unlearn. एक सीएमए में कहीं कुछ सुन लिया हो, फिर वो लाइफ टाइम के लिए मैसेज बन जाता है कि उसी पे फिर प्रैक्टिस करना चालू रखते हैं सर. So we have got some pertinent questions. First, about the hot topic that is going on about COVID vaccination. Still, there are a lot of confusion among doctors also. There is a contraindication for taking COVID vaccine for patients who are taking blood thinners. So can you elaborate something more on this, sir?
The contraindication for blood thinners has been mentioned only by Covaxin, that is the Bharat Biotech vaccine, and not Covishield. So, of course, I don't know the reason why Covaxin has said that. Maybe they have seen something in their studies. As you know, the phase 3 trials have not been published. Only the phase 1 trial recently came into the Lancet journal. But so I would say Covishield, which is the most disseminated vaccine, not a contraindication. Does not say that blood thinners are contraindication. For me, Covaxin should not be a contraindication. The blood thinner should not be a contraindication even for Covaxin. Maybe they are just taking abundant precaution. But I think
Okay.
that's
And a word on immunosuppression, sir?
it is not about immunosuppressants, but it is about how immunosuppressed the patient is. There are 2-3 areas in this, a little confusing. But if a patient is immunosuppressed, the patient is more prone to severe COVID and has higher mortality with COVID. Therefore, you must give the vaccine. So in the US, immunosuppressed patients are given priority for vaccination. But there are some areas where if the patient is on metastatic therapy, chemotherapy for metastatic disease, during chemotherapy, the oncologist may advise against giving the vaccine at that time, principally because the vaccine may not work, may not give an antibody response while the patient is on immunosuppressive therapy. That is one area. And the second area that is more complicated is it is believed that the mutant strain in UK arose because of COVID occurring in an immunosuppressed patient, meaning an immunosuppressed patient got COVID, the virus lingered in that patient for a long time, lingered enough to get several mutations,
Right.
more than 20 mutations. So immunosuppressed patients, because they are sources of mutation, should get the vaccine earlier because of this reason also.
Okay. Sir, how to deal with the demand of on-demand multivitamins depending upon the age? It's a very common dictum. लोग आके पूछते हैं 40 साल हो गया है तो मेरे रिलेटिव ने ये बोला अगर आप नहीं लिखते तो वो ओटीसी से बाय कर लेते हैं आप लिखते हैं तो इरेशनल प्रिस्क्रिप्शन में डायलेमा में फंस जाते हैं how would you deal with this, sir?
So first of all, if the patient has trust in you, has been your long-standing patient, I don't think it is difficult to convince the patient that you don't need to take this plus this plus this. And the best way to convince a patient to do what is correct is to explain why it is correct. When we write a treatment tablet, vitamin B12, 1,500 micrograms, we are doing an unscientific thing in most patients. So first you can get hold of your science correctly, what you need in a vegetarian patient who does not have pernicious anemia but has B12 deficiency. What you need is just 15 micrograms of B12, which is there in Bicosol, Plexfort, Neurobion, cheap medicines. You don't need meganeuron OD or some such high dose drugs for patients who have deficiency only due to vegetarianism. 15 micrograms of B12 is equal to 150 grams of chicken. They have had their share of B12 in just this dose. So explain to the patient what they need and what they don't need. And also suggest, patient will also accept dietary suggestions. If they say, I want iron supplement when they don't have iron deficiency, tell them that iron is good in nachni ki roti or in til, etc. I think you can replace the supplement advice with dietary advice also.
Okay. And how to increase the sensitivity about acceptance of adult vaccination, especially flu, pneumococcal and everything. We explained a lot. We try to do the best, hand out them the visualate and everything. Still, the uptake for adult vaccination is low. I don't know whether COVID will change it or not. But as of now, it is a big bottleneck for adults to get vaccinated.
I think the bottleneck is from both sides, the physician side and the patient side. I still have problems remembering that every person above the age of 65 should get the pneumococcal vaccine. I sometimes forget to give the pneumococcal vaccine to the patient. Problem is also from our side. We forget to recommend. But yeah, and in the influenza vaccine, now the recommendation about influenza vaccine, at least in our country, is the patient should take it if the patient wants it. Meaning you suggest to the patient. Not like polio vaccine, which is compulsory in children. Influenza vaccine not compulsory in adults. You have to give a suggestion to the patient that you have asthma, you have COPD, you have cirrhosis. I would like you to take the influenza vaccine. And the choice is, it's a shared decision. A pneumococcal vaccine, on the other hand, should be enforced more vigorously. That please take the pneumococcus infection can be more lethal at your age than the influenza infection. Influenza infection, uh, fortunately in India, is not rampant like in the US. So I think some are shared decisions and some are our enforcements on the patient.
Okay.
And
So,
COVID will change it, as you rightly said. COVID will change it. People now are demanding influenza vaccine, as you already know.
yes. Sir, your take on antibiotics in adults. See, for example, in a lot of patients, we see that after giving a full dose of paracetamol, maybe 650 milligrams, 3 times a day, still the fever comes in between and there are spikes. And obviously, whatever is the diagnosis, patient gets disturbed with the spike of fever. How to handle this? Mefenamic acid, diclofenac sodium, what next?
None next. NSAIDs for fever should be used only if the patient has such a severe headache during episodes of fever that the patient becomes miserable. Don't treat fever just for the sake of fever. Unless he has hyperpyrexia 105 plus, tell the patient that fever is your response to the enemy being the virus or the bacterium. Your response. The better the response, the greater will be the chances of defeating the enemy. Fever is your ally. Fever is not your symptom of discomfort. Fever is your symptom of fighting infection. Once you explain this to the patient, tell them that in COVID, there is a lot of talk about not treating the fever at all, like low-grade fever with paracetamol. Do not treat unless the patient is very uncomfortable. Oh, even though I give paracetamol fairly regularly, but we are learning that in COVID, an immune response should be judged by the amount of fever that the patient has. So you have to convince the patient. I believe one area of patient education is educating the patient on small things every time the patient interacts with you. That way, the trust is built. Patient knows you are talking sense, not talking nonsense, and patient can recognize that you are talking sense or nonsense. Talk nonsense, patients know.
Okay. And your take about fixed dose antibiotic combination, this with that, broad spectrum antibiotics, which are the at times the flavor of the season.
Uh, two things that we as outpatient practitioners can do, should do, without fear of losing patient. मेरा patient चला जाएगा मेरे पास से, बाजू वाले के पास चला जाएगा. That fear is usually your underconfidence, not
Right.
the fear of patient.
True.
Two things that we should do is underprescribe antibiotics and underprescribe NSAIDs. I tell my those who listen to me, I tell them that you're starting this week, your NSAID prescription or dispensing of anti-inflammatory non-steroidal drugs like Brufen, etc., would reduce 50% starting this week with no arguments, and gradually reduce your NSAID 10% of what it used to be. You must do that. Never give NSAIDs more than 5 days, etc. Now about combinations of antibiotics. The commonest combination used is in diarrhea. Ofloxacin or nidazole, for example, is a combination, and that is the oxygen of many people, O2 kind of thing. Now we have to understand that the infection is either viral or bacterial or amoebic when the patient comes with diarrhea, and the most common is viral. So both your drugs are useless. If the patient comes with vomiting before diarrhea, if the patient doesn't have significant cramps, then you think of viral first and treat with symptomatic drugs, probiotics, etc. If the patient comes with acute diarrhea and you want to give something, give one drug, ornidazole or ofloxacin or cefixime. Don't give combinations of drugs, and because your diagnosis, that means is not you've not made an effort to diagnose whether it's amoebic or bacterial. You must make an effort. Treat one thing And once you start thinking, you will obviously know that this looks like amoebic or this looks like bacteria.
Right.
Antibiotic combinations are another one combination that I hate is linezolid with cefixime. I don't know why it is there. Why does it? But please don't use. Think of the organism and treat that one organism with one antibiotic.
True. And the last question, as we are running out of time, the combination of clopidogrel with aspirin. The patient who underwent a procedure sometime long back, and unfortunately we do not have any good tradition of regularly following up with the cardiologist or physician. They keep on taking this combination for lifelong, and nobody dares to stop it because it may cause some issues. So specific indications and the time duration that it should be given. Because ultimately the cat has to be bailed by us, the family physicians.
The cardiologist will never bail this cat. I have seen cardiologists, even with follow-up after 1 year and 2 years, their pen does not remove that Rosuva's gold, which has 20 platelets, or Clopiva's AP, which has 20 platelets. Their pen sticks to the dual antiplatelet. For them, GI tract, brain hemorrhage is not important as far as my stent is protected. It's just like those orthopedic surgeons who don't care about the heart when they give 15 days of NSAIDs. They think the heart is a pump to deliver their NSAIDs to the joint. That is what they think. Right? Cardiologists also do not remove the dual antiplatelets. I have not seen any cardiologist till date remove dual antiplatelets and convert to zinc. I have not seen. I have seen so many prescriptions. The onus is upon us.
Yes.
And after 1 year, you have to, unless the patient is very aggressive atherosclerotic disease, one stent put this year, second stent put this next year, third stent put next year. If the patient has very aggressive disease, you have to counsel. Even the patient will be scared of stopping. You have to counsel the patient. Now your brain hemorrhage chances are greater than your stent blockage chances. Please stop. And in these COVID times, you have a very bad problem with this. On dual antiplatelet, they get admitted with hypoxia and they have to be given enoxaparin injections. It becomes triple antiplatelet therapy, triple blood thinner therapy. Then we have to stop the dual antiplatelet without consulting the cardiologist. The cardiologist always plays safe because it is their field. But we, as you said, my final statement here is this: just we, family physicians of Ahmedabad Family Association, you have now become the most important group of medicos in COVID times. And your importance has to be not just maintained, but it has to grow. You have found your place in the field of outpatient management.
True.
You must stabilize that place by increasing your learning.
Thank you very much, sir. That was very useful and a wonderful session, I must say. And I think we can go on with this. The questions will keep flooding the whole day. But as you said, the rule of the mule of 11, we have got a time of 45 minutes, so we have to stop here, sir. Thank you very much, sir, for that wonderful sharing of knowledge. Thank you very much, sir. Thank you, sir.